go by. Cellophane flowers of yellow and green towering over our head.
Hart actually has been involved with the Texas Medical Association for many years in doing these phenomenal stroke conferences and educating practitioners all over the state. So we're extremely fortunate every time he speaks with us because he's got a lot of tremendous knowledge. So when he says what's new in stroke, you can believe it's new.
So we'll shift gears a little bit to talk about stroke, and I'm going to, there's a picture that goes to the right of there of a big stroke. It's not showing up. Yeah, and that's okay as long as some of my other pictures don't, but we'll see how it goes. Stroke's a big problem, particularly in geriatrics, and this slide just shows some numbers. It's predicted that the total number of strokes is going to peak about 2018 with 1,100,000 strokes per year as the baby boomers hit the stroke-prone age group. So as I'll show you in a minute, while we're winning the battle against stroke on a per-age incidence rate, because of the aging of the population, those of us who take care of stroke patients are going to be busy for the foreseeable future because of the large numbers of anticipated strokes. And my last couple slides will reinforce this business about most strokes can be prevented using stuff that we have already proven in clinical trials, but which are currently underutilized. So within this survey of what's new, I'm going to develop two themes. The first is that stroke isn't one disease. Stroke is fever, or stroke is pneumonia. And you don't ask if something is good to prevent stroke. You have to say, of the major causes of stroke, is this therapy good for that specific cause? So this diagram outlines the major causes, and you can see you can have clots from your heart if you have atrial fibrillation, and certain types of blood thinners would be good for that. If you have a blockage of cholesterol in your neck, turns out the blood thinners don't work all that well, but reperfusing with surgery or sometimes with angioplasty works. So don't think of stroke as one disease. Again, it's pneumonia. And just like we don't ask whether penicillin is good for pneumonia, you say, well, is penicillin good for pneumococcal pneumonia? Yes. For lupus pneumonitis? No. So it is with stroke. So don't think of stroke as just one thing. My second theme is going to have to do with randomized trials and the need for randomized trials when we recommend preventive therapies. And I'll show you an illustration of that among my choice of top 10. But as I've been around long enough to know that docs often recommend things for prevention with the very best motives, hoping that we help people. And then we finally do randomized trials, and some of them don't work, and some of them actually are harmful. So that for prevention, for chronic prevention, we really have to base things on randomized trials rather than what should work based on laboratory studies and what have you. So as an introduction to the different types of stroke, this is a little hole, a lacoon there in the thalamus, shown by the blue arrow, and that's caused by a degenerative arteropathy of the thread-like vessels inside the brain. And we call this lipohyalinosis, and it's the most common cause of stroke in San Antonio due to the ethnic mix and the high prevalence of type 2 diabetes. We see more of these strokes than any place else in the country, and it's the predominant type. And this is a human injection specimen of those tiny vessels. They're really so tiny we don't even see them on arteriograms. And so for patients with this problem, operating on things in the neck or giving them anticoagulants hoping to prevent clots from the heart isn't the right thing to do. On the other hand, this is an arteriogram. Patients facing to the left there, and that's the common carotid artery in the lower right. And the arrow is pointing to this atherosclerotic plaque that's almost squeezing off flow to the brain. So at endarterectomy, you see these big greasy cholesterol-laden plaques. This one has a red thrombus overlying it. And this is a different cause of stroke, and which we would approach differently than this degenerative arteropathy of the thread-like vessels. So I'll show this somewhat facetious slide. When I was putting together my top 10 for stroke, as always, 6 months in advance, you're always ambitious about what you're going to do. So I'd imagine this systematic review based on modern consensus techniques. But as always, you get to the week before, and I just went through the stack of reprints and asked my colleagues and selected a bunch. But I selected them based on their influence on my day-to-day management of patients. So I'm not going to talk about genetic insights in the Icelandic population that may eventually translate into important results, but things that would help me at the bedside. So I listed these in your handout, and I put together 10 of them, and I'll have some time at the end if there are specific areas that you'd like to talk about, but I'm only going to go through 3 in detail that make a couple of points. So these are my top 10 of the last 2 years. And the one I'll start with is from the Lancet. And this is a pooled analysis of individual patients from randomized clinical trials looking at the benefit of TPA, thrombolytic therapy for acute stroke. So this isn't a conventional meta-analysis where you take published results and glom them together, but these investigators took individual patient data from all of the trials and put them together so they could be analyzed really as one large trial. So 6 trials testing intravenous TPA within 0 to 6 hours of stroke onset, all using about the same dose, and they ended up with 2,775 patients, mean age 68 years, and NIH stroke scale of about a moderate size stroke. So these are pretty much your everyday patient that comes to the hospital with a stroke. And thank heavens this figure showed. And what it is the odds of a good outcome versus the time from stroke onset to receiving IV TPA. So if you look over there on the left, you can see that your odds of a good outcome means going home with essentially no functional deficit. So you might have a Babinski or a little hyperreflexia, but you're doing pretty much everything you did before. And that solid line is the point estimate of good outcome with a 95% confidence interval, the margin of error indicated by the dashed lines. And you can see that the time to treatment influences the likelihood of going home without a deficit in these randomized double-blind trials. Now in the US, approval of TPA is within 3 hours of stroke onset. So that's the vertical line, so 180 minutes. And so we only treat people here to 180 minutes because the seminal individual studies only showed benefit to 180 minutes. But this data pooling suggests that there might be some, albeit smaller, benefit going out to 4.5 hours. So you can see the lower limb of the 95% confidence interval doesn't touch 1, meaning no improvement, till you're out to 270 minutes. So this intriguing analysis has stimulated the stroke world to wonder if we shouldn't go back to the FDA and expand the time window for treatment. But for right now, it's 180 minutes. And how this, and I think the next slide shows the odds, so this is just the numbers to go with that plot. Your odds of a favorable outcome is almost 3 times if you're treated within the first 90 minutes. So that's a risk ratio. If you translate that into absolute numbers, that means almost everybody treated within 90 minutes goes home with minimal deficit because the baseline is about 23%, so if you multiply that times 2.8, the overwhelming number of people that come to the hospital with ischemic stroke within 90 minutes get treated go home with no deficit. And then you can see as time goes by, that falls with, again, some benefit going out even to 6 hours. So how this changed my life is when we go to the ER and see people with an acute stroke, Usually they arrive and I arrive, and the family's coming in the car behind, and I say, oh, I've got 3 hours. So maybe I'll wait 15 or 20 minutes till the family gets here, because I'm going to treat them with this potentially dangerous therapy, and I kind of like to have everybody on board. They don't know me, they just met me, and I'm going to give them this thrombolytic therapy. And before this study, I thought that it was probably a reasonable thing to do. But now I know that time is brain, and as the minutes go by, you're sliding down that slope. And so it's made my life harder, because I have to decide when to treat at the soonest possible interval. So good news for the patients, and that is if we treat early, the chance of doing well are pretty darn high. But the decision, and you say, well, talk it over with the patient, remembering if it's a left hemisphere stroke, there's aphasia, and probably are not understanding. You know, they're arriving in an ambulance, there's a big light shining in their eyes, people are putting tubes in them. I introduce myself and say, I want to give you this treatment that usually makes people better, but it has side effects. So trying to deal all this with this in a setting of an acute stroke, the patient, I really wonder, is in a position to make a good decision. So it's complicated things, but we just move a little faster, and we try very much to shorten that time to treatment in order to accrue those benefits. So that was one of my top 10, and it changed because now I run to the ER instead of walking, and I sweat because I make the decision as much as I can with the patients and on a cell phone with the family, rather than waiting that half hour for them to get there. Intracerebral hemorrhage is about 1 stroke in 6. So these are primary bleeding into the brain rather than a blocked blood vessel. And you can see you wouldn't want to give thrombolysis to this type of patient. And generally, because it's infrequent, we haven't had very many clinical trials. But just so happens these last 2 years, there's been an unprecedented number of 3 randomized trials involving intracerebral hemorrhage that I've listed in the top 10. And I'm going to show you the results of one because it surprisingly shows the huge benefit of modest blood pressure lowering on this stroke subtype. So this is the second of my top 10, and this is the Progress trial, and it's a subgroup analysis of a randomized trial. Progress took patients, around 6,000 patients, who had prior stroke, TIA, or intracerebral hemorrhage, and randomized them to usual blood pressure care versus an augmented antihypertensive regime. And if you were randomized to active therapy, this is again on top of your usual blood pressure care, you were assigned perindopril, an ACE inhibitor, and at your doctor's wish, not randomized, but you could also, if you got perindopril, get indapamide, which is a thiazide diuretic. And what it showed was this, and that is if you looked at recurrent stroke and survivors of stroke who were assigned usual versus aggressive blood pressure control, there was around a 30% reduction in subsequent stroke of all types of stroke survivors. Interestingly, look how long it took before the curves start to separate. So unlike aspirin or warfarin, where we started and we see the effects immediately, it took a little while for the blood pressure lowering effects, around 6 months before the curves started to diverge, and then they just keep going. Such that in all patients with progress, in the Progress trial, there was a difference of 9 millimeters systolic and 4 diastolic, 28% stroke reduction. In those that got both perindopril and indapamide, 12/5, 12 systolic, 5 diastolic, 43% reduction in subsequent stroke. So pretty darned impressive. 12 millimeters isn't that hard to achieve with modern antihypertensive drugs. So this was a fairly low dose of an ACE inhibitor and a low dose of a thiazide diuretic. So nowadays inexpensive, well-tolerated, 43% reduction in stroke. Further, for neurologists, these were patients now who are not primary prevention, but people with prior stroke and TIA. And in the 80s, we were taught that once you had a stroke, it was too late. Your vessels were all calcified and choked up, and that lowering blood pressure might even hurt you because of the hypoperfusion in diseased vessels. So as we watch these primary prevention trials consistently show the benefit of blood pressure lowering, neurologists always wondered, well, does this apply to our patients, those after stroke? And progress then really put the nail in the coffin of the idea that it was too late to treat blood pressure. And in fact, these numbers are pretty impressive. So what I wanted to focus on is the hemorrhagic stroke. So these are people that these are the hemorrhagic strokes that occurred during progress. Of the 9 millimeter systolic, 4 diastolic reduction, look over on the third row down, hemorrhagic, reduced by 49%. And these are people that entered the study with hemorrhagic stroke, and what happened to all types of strokes if you entered with a hemorrhagic stroke. And again, now it's turning it around at a 50% reduction by 9/4. So what, again, impressed us from this randomized trial is the very large benefit by fairly modest blood pressure lowering using tolerable drugs. So that was number 2 of my top 10, and what I tell our neurology docs is that blood pressure control is among the most important things we can offer stroke survivors, and to delegate that to somebody else and say, oh, you know, we've done our duty by handing them an aspirin really isn't enough. If you're not comfortable taking care of blood pressure and you're going to rely on a primary care provider, then make sure to communicate that and to follow the patient carefully and make sure that the blood pressure is in fact treated. So the third of my top 10 is I give as an illustration for why we need randomized trials. I work half-time for the clinical trials group at NINDS, as I have for the last 7 years, organizing randomized trials in Parkinson's and ALS and stroke. So I say that as a caveat. I'm a true believer in randomized trials, arguably to an extreme. But this came in the mail in one of our Neurology Today things. This is Dr. Gwartz, the Gwartzian approach to treatment. And you can see there, and I say that a little bit with a snide smirk, but in some situations, in acute pain and in situations where the results of the disease are uniformly fatal, we may not need randomized trials in everything. But in illnesses, most illnesses, where the natural history has a variability and is not predictable, for prevention, not treatment, but prevention, we certainly need randomized trials. Dr. Gwartz wasn't alone in his standard of evidence base. And as recently as in 2000 in the New England Journal of Miracles, these statisticians from Yale questioned whether with modern statistical techniques we'd come far enough that we could evaluate therapies without randomized trials. And so they looked at observational studies, a group of them, and then compared the results of observational studies to the subsequent randomized trials, and they said, gosh, they look alike. And maybe we're to a point where we don't have to do these expensive, complicated randomized trials. We can get the answers from observational studies. And that leads into my third on my list of top 10. This is warfarin, so Coumadin in North America, versus aspirin for people with intracranial atherosclerosis. And this was a study from 1995, an observational study that showed that warfarin was about 70% better than aspirin. So 1995, gosh, that's all the data we had, and we started treating people with intracranial atherosclerosis with warfarin, hoping to achieve this huge benefit by this fairly sophisticated, non-randomized comparison. But to the credit of that long list of investigators in 1995, they then said, we need to test this in a randomized trial. So they then, in 95, organized the WASID trial, which was published earlier this year, comparing warfarin INR 2-3 to aspirin in patients with symptomatic intracranial stenosis. And here are the key results. If you looked at stroke or vascular death, which was their primary outcome, there wasn't a 70% reduction by warfarin. In fact, it was a dead equal. If you looked at all stroke, a few fewer strokes, but then a few more deaths from those assigned to warfarin. So we went from a good observational study showing a big effect of warfarin that led to clinical practice being changed for a lot of us, to now then a randomized trial showing really no difference. And if there is no difference, aspirin wins because it's easier to take and doesn't have monitoring and other problems. So I'm going to skip to this editorial from the New England Journal and to reinforce this idea of randomized trials when we're talking prevention. As most of you know, in the 90s, hormone replacement therapy was widely recommended to postmenopausal women to prevent stroke and heart attack. Consistent results of observational studies showed a reduction in women that took hormone replacement therapy. So now we have 4 randomized trials carried out showing small increases in myocardial infarction and stroke in the first 6 months of hormone replacement therapy. Small to be sure, but not protection. There's not protection. And as you know, there's more to the issue of whether to take hormone replacement therapy than just vascular events. But no matter how carefully you look at observational data, there's always the concern that there are imbalances that we don't appreciate. And probably in the hormone replacement therapy trials, it had to do with education and the things that go with that to protect your health. But you're never sure without a randomized trial. So WASID is listed there about 4 down. This is intracranial stenosis. I grew up in the 80s in which we tried aspirin for prevention of stroke, and if that didn't work, we often switched people with cerebrovascular disease to warfarin. And now we have 3 randomized trials that have come out in the last 5 years, all showing that warfarin is no better and possibly worse than aspirin in people with cerebrovascular disease. So I'm going to come in a minute to cardioembolic stroke. But to think that warfarin is the tough big brother of aspirin and that you really want to use it when aspirin fails, Spirit, WARS, and WASID all showing aspirin either ties or wins, and then Esprit is still ongoing. That was patients with atherosclerosis of the cerebrovasculature. And now I'm going to go to atrial fibrillation. So a cardiac rhythm abnormality whose main problem is stroke. This is a left heart filleted open. In the upper right, that big white area is the smooth-walled left atrium proper. And sticking out toward the left is the left atrial appendage, the vestigial part of the left atrium that has these kind of trabeculations. It's an area of stasis even in normal sinus rhythm. It's this little pouch from embryologic stages. But in atrial fibrillation, the blood just kind of sits there and you form clots, and you can see there that little thrombus that's about 5 millimeters in size sitting in the left atrial appendage. 5 millimeters, not too impressive if you're talking about a pulmonary embolus. But big enough to block off the middle cerebral artery and cause a big stroke if that clot would break off and go to the brain. A-Fib, 1 in every 6 strokes, and it goes to 1 in every 3 in strokes occurring over age 75. So the older you are, the bigger threat atrial fibrillation is in absolute and relative terms. So we know, in contrast to those studies I showed you about warfarin versus aspirin in cerebrovascular disease, that warfarin is far superior to aspirin for preventing stroke and atrial fibrillation. There were 6 randomized trials carried out, one of them that we led here in San Antonio called the SPAF trials. But a couple of years ago, we again pooled individual patient data from all of those trials, and what you can see is whether it's for primary prevention, that is A-Fib patients with no history of stroke or TIA, or secondary prevention, there's roughly a 50 to 60% reduction in stroke by warfarin over aspirin in people with atrial fibrillation. So not at all like the effect of warfarin versus aspirin in people with cerebrovascular disease. Coming back to my theme that a stroke is not one thing. If you're an A-Fib and it's coming from your heart, it's very different than if you have a clogged up atherosclerotic artery. So having said that then, which patients with atrial fibrillation need warfarin or would benefit the most from warfarin? And number 4 on my top 10 list is the validation of the CHADS-2 predictive scheme. CHADS-2 was developed by a guy named Brian Gage, who presented this at the stroke meeting in 2001. That was right after the 2000 election, and he was careful to point out that this was developed before CHADS became a watchword after that election, and it's an eponym for heart failure, hypertension, age, and diabetes. You get 1 point. And then stroke or TIA, secondary prevention, you get 2 points. And so in JAMA, he looked at a hospital discharge cohort of AFib patients, and he looked at the CHAD score and he followed them, and he showed that if you had AFib according to your CHAD score, you had this stroke rate. And that was fine, and most of us said, good, but validate it, because whenever you develop a scheme, gee whiz, it's predictive, but you need to validate it in an independent cohort before we're really sure that we can use it. And so Brian then got together with the rest of us, and we pooled all of our individual patient data from our clinical trials, the control data, and we, in circulation last fall, looked at 2,000 AFib patients without prior stroke or TIA, given aspirin, to see if CHADS would identify those with a high enough risk who'd benefit from warfarin. And it turned out, as you can see there, that the CHAD scheme was predictive. So if you were one of the quarter of AFib patients with a low CHAD score, your risk was so low, really 0.8% per year. That's about the population risk. You wouldn't want to anticoagulate. 1 or 2, 2.7% per year. The risk of warfarin, or the benefit of warfarin, would be about 1.5% per year, so number need to treat of 67. Certain patients, I think we talked to them and might be interested in taking warfarin for that kind of benefit after you explain it. But the 12% who were high risk are going to benefit from warfarin enough that we'd sort of twist their arm and say you'd be foolish not to take warfarin in that situation. So does everybody with AFib need warfarin? No. And we have now a predictive scheme, CHADS-2, that was proposed and looked at. These are the control groups of clinical trials. But now we also have a second validation, and this fell outside my 2-year window of important studies, so I couldn't put it in. But this was the Kaiser Permanente California HMO population of 11,500 outpatients with AFib. And they also looked at CHADS, and you can see that the CHADS-2 scheme worked very well in predicting stroke in these people as well. And so probably even a better validation, because these weren't hospital discharge patients, but were outpatients. So the patients that come in to see doctors, old folks with AFib, and you have to decide whether they're at sufficient risk that you'd recommend warfarin. Now, and look at these outpatients now. 54% of them were low risk. As you'd expect, people in the hospital have more heart failure and other stuff. So I think we now have the data to allow us to stratify risk in old folks with AFib and pick out those who benefit most and least from anticoagulation. And here's my paradigm. If you're high risk, and that's about a quarter of outpatients with AFib, warfarin. If you're moderate risk, consider whether there's access to good monitoring. If there's predisposing factors to bleeding risk, so they've got varices or they've had a couple of prior GI bleeds, and then patient preferences, because their patients are very interested in doing everything to prevent a stroke, and some that have a more casual attitude. And then low risk, about a third, where aspirin is sufficient. time being what it is, I didn't put in the SAPPHIRE trial, which compared angioplasty and stenting to carotid endarterectomy, but I just threw in this slide because my spouse, who's a nephrologist, one of the cardiologists downtown told her that carotid endarterectomy is passé, that angioplasty and stenting have been proven, he said. And again, I give you my caveat that I'm a clinical trial person, and you really got to prove prevention therapies to me. These are the randomized trials to date comparing carotid endarterectomy to angioplasty with or without stenting. And the first two, wall stent and cavitas, were carried out before the distal protection devices. So what they did is they went in and they blew up this balloon around that big carotid plaque that I showed you earlier, and guess what happened? All the grunge in there floated up into the brain and caused trouble. So very quickly they figured out this isn't good, so they developed a distal protection device. So they slide this little thing through and blow it up, and there's a net. And then when they blow up and fracture the plaque, they collect all the stuff and they pull it out. So the first two studies, which aren't that old, were done in the era before distal protection devices, the randomized trials. Wall stent was negative, and cavitas was a draw. The Brooks study of 104 patients was indeterminate. With 104 patients, 15 each arm, there weren't enough events. And then SAPPHIRE is the one that's listed on your handout, and I think I put the key results in your handout. It received a lot of attention when it appeared in the New England Journal last fall because they took patients who were high risk for carotid endarterectomy because of coronary disease and randomized them to endarterectomy versus angioplasty and stenting. And what they showed was, not surprisingly, fewer MIs in this selected high-risk group. And if you looked at neurologic outcomes, they were non-inferior. So it was essentially equal. But I show this because of the published randomized trials. Can we say that angioplasty and stenting has now replaced carotid endarterectomy? No, not at all. And if you just look at this, you'd say, well, we got a negative and a neutral. Yeah, but that was before the distal protection. And then we have this SAPPHIRE one that's not inferior. Again, not a lot of patients. So thank heavens, 4 ongoing trials that we're well into them. So there's approximately 5,000 patients now randomized already in these 4 trials. And we'll soon have good information about that. But about the efficacy of angioplasty and stenting versus endarterectomy. But for right now, we don't know. And the other thing we don't know is the durability. So we know that in coronary circulation, you angioplasty and stent, and they often come back. Endarterectomy, carotid endarterectomy, is very durable. We have 10-year follow-ups showing that the chance of recurrent stenosis at the site of the endarterectomy is 1 or 2%. So as you glean then, I think in patients who can safely undergo endarterectomy, I think for right now, I would recommend, and I am recommending endarterectomy, unless there's some cardiac condition that would make it dangerous. And as I told my spouse, not to let your friendly cardiologist with his catheter tell you that endarterectomy is passé. Oh, and this is just to show you, these are our same studies I showed you before. There's something appealing about not having your artery operated on, and scares the heck out of me too. But the 30-day stroke or death rate, even in SAPPHIRE, which is the one that's quoted by the folks who like angioplasty, 30-day stroke or death is equal 5%. So it's not like it's risk-free. Myocardial infarction lower, if you're at risk for myocardial infarction. And then again, the long-term, since we're not just treating here for a year, we'd like a 5-year outcome, is really not known. So I'd just say go slow with that. So what's new in stroke? I've touched on a few of these. WASID maybe is not something you run into every day, but I think is a good example of why a sophisticated observational study led us astray for 10 years until the randomized trial came out. And I'd like to conclude with a couple of slides about stroke is preventable. We've known over the last 20 years with antiplatelet therapy and with statins and with blood pressure lowering that we can reduce stroke. And this is deemed by people who seem to know the best stroke epidemiologic study existing, and that's in Oxfordshire, where they do door-to-door assessment for stroke and all this stuff, so it's not just hospitalized stroke. And it's an affluent, well-educated population in a prevention-oriented healthcare system. So primary care docs in the UK are rewarded by the number of patients with hypertension who are below a certain level. They really have incentives to do prevention. And during this interval of 81 to 204, there were large increases in the use of blood pressure lowering drugs, lipid lowering drugs, and antithrombotic agents. And they found a 40% reduction in stroke incidence in a very well done epidemiologic study over this interval. We haven't seen that type of decrease in epidemiologic studies here in the US, and maybe it's the quality of the studies. Probably it's because we're not in a prevention-oriented system where we're making maximal use of interventions that we already know reduce stroke. So I will conclude again with this slide, and would hope to remind you then that dependent upon whether your threatened stroke is coming from a buildup of cholesterol in your neck, carotid stenosis, and we have endarterectomy, and then on the horizon angioplasty and stenting if it's from intracranial stenosis. Cardiogenic emboli, A-Fib is the most common, and we have warfarin for those at high risk that reduces stroke by about 2/3. And currently, our group is leading a big trial of secondary prevention in people with small artery disease, so those thread-like arteries, stimulated by what we see every day, and that is half of our strokes at University Hospital are from that cause. And if you look at nationwide stroke registries, that's a real distortion because it's more evenly distributed. So with that, I'll conclude, and we have a few minutes for questions.
Are those thread-like arteries that you're talking about, they're the ones that cause the thrombotic stroke, not the hemorrhagic stroke?
They cause both. Good point. And that is these thread-like arteries, when they degenerate, they get this hyaline in the wall, and the lumen narrows and they thrombose. And then they also, that hyaline weakens it, and under the influence of uncontrolled hypertension, they rupture. So we see these little holes, these little lacunes, but we also see about twice the risk of intracerebral hemorrhage. And in our studies that we're doing now, it's two-pronged. We're lowering blood pressure a lot, so going beyond progress to new levels of blood pressure lowering in an effort to prevent the hemorrhagic strokes. And then we're using different antithrombotic agents, stronger antithrombotic agents, to prevent the ischemic strokes. Now, one of the concerns, a holdover concern, is if you're going to go, under 120 with systolic in the setting of these sclerosed blood vessels, could you hypoperfuse and cause, if not strokes, vascular cognitive decline? So we're measuring very carefully cognition, not just doing mini-mental status, but different tests for executive function. So this is a big attack on small artery disease in both of its manifestations, hemorrhagic stroke and ischemic stroke, which again is, if you put together the hemorrhages and the ischemic strokes, maybe 2/3 of the strokes we see at University Hospital are from this small artery disease. Yes, ma'am.
Have there been any studies of cognitive status before and after CABG surgery?
Oh yeah, no, that's gone back a long way. And there's actually a nice review by the two neuropsychologists at Johns Hopkins within the last couple months in Annals of Neurology. So lots of information on that, and it's kind of scary stuff. If you way back in the late 70s, when CABG started being done on a big scale, they did CSF CPK-BB levels. So that's the CPK that comes out of neurons, and they found that 100% of people undergoing CABG had big elevations in CPKBB, meaning they lost neurons. That seemed to correlate now with maybe a 2 or 3% clinical cognitive decline. And then when MRs came, they did pre and post MR with diffusion, and the chance of having a little bit of ischemia with CABG is about 1 in 3. Again, the clinical estimate's much lower. So everyone thinks that CABG leads to subclinical brain injury, and one of the hot topics is what we can do. At first you'd say it's because of hypoperfusion, because they put this big tube in your aorta and they give you non-pulsatile flow at a mean arterial pressure of 60. You'd say, oh, well, you know, turn up the pump and make it higher, but it's probably embolism. It's probably most of the strokes are when they put the tube in your aorta's full of atherosclerosis, and it's probably emboli. So another alternative would be some type of a protection device like we're using with angioplasty. But when you mention CABG to a stroke neurologist, we all turn pale because most people do fine, and thank heavens the clinical neurologic risk is on the order of 1% or 2. But what goes on subclinically is scary, and we certainly need things to help. Yes?
The reason I ask the question is because I've actually seen the reverse a number of times, where people have had successful coronary artery bypass grafts, and their cognitive status improves unbelievably. I mean, people who had lost hours out of their day never had it happen again. It's incredible.
And there are some big studies, neuropsychiatric studies post-CABG, and there are a subset that get better. And your temptation is to say, well, cardiac output's better, and so da-da-da. I suspect it's as much due to the medicines that you're not taking as the idea that you're perfusing better. The brain circulation is great at if you've got any cardiac output, it's going to shunt it to the brain. So it's pretty good at stealing all the blood that it needs. So most folks from CABG, their cardiac output only goes up a little, and the brain was taking all it needed from there anyway. So, but there's a rich literature on this, and so.
Great. Thank you.
Sure.